regards to potassium and calcium, are we supposed to like increase those as well? Like taking potassium or pills or calcium?
So what I would like to say, the channels, potassium, calcium channels, it's not the amount of potassium or calcium you have in your body. This is setup of mechanism, physiological mechanism, have to open gate for different proteins and enzymes to kick up certain process in our body, make our muscle move, our brain to think, and many other processes. It's not dependent of how much you take in those microelements. Any other questions?
First, no, you go ahead.
That was my same question, but when I found out that it was a choline factor, everybody started telling me to take that orally every day, trying to replace it. But I don't think that would work, right?
It doesn't replace it because it's not really absorbed so easy through your gut and going to the blood-brain barrier and other. And the mechanism of recycling acetylcholine, I show you. So every time after it degraded, it coming back inside the cleft and nerve terminal reabsorb it and synthesize this again. So it's like the best ever. I hope we can do this recycles in life, not only with acetylcholine, with everything. You know, we've tried this, what coming actually this idea of recycling bottles and other when you could. Our body set up and this for many, many years, many things. And that's the best design ever. I'm not sure we could even replicate this, but amount of choline taken, the same like with microelement, will not affect it. It should have specific, we say, vehicle to deliver to the cells. Itself, it doesn't go there. If I'm wrong, Dr. Perishek, help me.
And eventually it started hurting my stomach.
Yes, yeah, it doesn't matter how much chlorine you drink. It's only may make it cleaner, but you have enough of chloric acid in your stomach. You know, it's just, if you even put there even nail, it could be degraded fast. So don't add it.
How long should pain last? Like in the morning time when I wake up, my hip leg area is like in major pain, trying to maneuver.
Yes.
And once the medicine is in.
So the pain, we didn't discuss about it, but because muscle inactivity, and during the night specifically, it make you be uncomfortable. In the morning, you need to warm up until start moving muscles and get good range of movement. For this kind of pain, we usually recommend Neurontin, one of the medication which block GABA receptors, decrease information about pain. And many times, because joints involved, just anti-inflammatory medication, but this clearly symptomatic therapy. It might help.
Well, in thinking about the pain and problems with movement, so with things like, you mentioned massage therapy before, things like water therapy or those kind of exercises that are for other autoimmune diseases people seem to benefit from, would it be the same for LEMS?
So I would like to say one very interesting thing about movement. Even this massage works increasing acetylcholine in the cleft. It's very temporal. It's not less than 1 to 2 minutes. Just adjust your body and feel better. Probably will get up from the chair. But then you need something which constantly give you ability to keep the same amount of acetylcholine inside of synaptic cleft, and this is supposed to be help. And this help exactly from the therapies what I said, increasing, stopping from degradation, or removing antibodies. It's very important. The difference, classical difference, what we say in a textbook between myasthenia gravis and LEMS. Myasthenia gravis, the more you do exertion, the more you get sick. It means in the morning you're active. You get up, you start walking. In the afternoon, you start getting ptosis, your eyes worse, you couldn't walk, and you're getting very exhausted. With the LEMS, you wake up in the morning tired, and then you do small exercises, give you energy, and may sometimes for 1 2 hours, and then you get back like myasthenic patient, because it's not enough to maintain all the time. But overnight, you have pretty good amount of acetylcholine and presynaptic terminal of the nerve, which is waiting to be released. So you warm up a little bit, it's releasing, giving you a temporary boost, you're walking, doing something, and then you're exhausted. So this is kind of a fundamental difference between two of those disorders. Yes?
When, because several patients mentioned the pain, is it a special type, is it just muscle pain, like just in the hips, is it all over, or?
This is what I try to describe. I don't think it's specific muscle pain. It's a joint pain because when muscle immobile, they affect joint as well. They got like stiff, and you need to work them up. It could be muscle pain as well because muscle. During even night when we're sleeping, there is constant release of acetylcholine, maintain tone of your muscles. But if you cannot maintain this tone because all calcium channel block and it's very minimal, your muscles got tired too. They always like relax more than you would like to. So in the morning to push up without medication or something, you feel you're tired. You need to you feel like you're stiff. You need to stretch and all that. This is a problem. So it's I think it's a combination of both. Dr. Shea, what do you think?
We'd like you to come up.
Oh.
We're kind of moving into a question and answer period. We'll put the two of you up here together, just trying to
Yeah.
finish.
Keep in mind, he's my mentor. He knows
Yes,
more.
I think, the mentor and the mentee, here we are.
Yes.
And so, and this is a great opportunity because you're getting them for more than, was it 10 minutes on an average visit? And,
No, we've
here-
actually spent up to 40 minutes.
40
approaching.
minutes, and thank you for doing that.
Yes.
But in most cases, it's your opportunity to ask that burning question. Now, we may have some questions to start you off with, but, and so, can you talk a little bit about the vision situation in LEMS and how that can progressively get worse, or when do you start noticing it, or is this disease, could it ever be diagnosed by an eye physician? Have you ever seen referrals from that?
Well, it's usually not the most prominent symptom. I don't know, how do you guys feel about your vision?
Yes,
Do you have double vision?
Patrick had a palsy.
Sometimes. You have some vision issues, right?
I've been having vision issues since May of last year.
Yeah.
It's progressively gotten worse. Technically, I can see none of those lines, even with the reading glasses on. I know that there's something right there, and I keep moving around and keep blinking. I'll eventually kind of make out what it could be or should be, but none of the slides you guys provided today, I couldn't see at all. Looking at this business card that's here, I'm having to adjust because I won't be able to see it even with the reading glasses. So if I take them off, I can probably get closer to what it is. At my desk right now, I have a magnifying glass, so sometimes I'm using it, sometimes I don't. Glasses on, glasses off. So that's what said, I cannot wait until the 10th to see what we can do different because it's definitely gotten worse. During the day, when I'm tired, he did say that I have ptosis of the limb, the line lid on the left side.
Yeah.
It definitely pretty much closes.
I noticed that,
We've
yeah.
done some treatments where you'll put ice, somebody put ice on for a couple of seconds, and then you'll see that the people, it'll open up for me, but it's.
So this is one of the differences. This is one of those things where the doctor and the patient will observe different things. Okay. Now, just to contrast with a disease like myasthenia gravis, our patients who have myasthenia gravis, and they come in with eye problems, they have vision problems, their eyes are like this. This eye's pointing this way, this eye's pointing this way. You know, you look, I look, anybody look, you don't need to be a doctor to say there's something wrong with this person's eyes, okay? When we see a patient like that and they have a little bit of ptosis or that droopy eyelid, you know, many experienced doctors would immediately start to suspect myasthenia gravis. Okay, an eye doctor would certainly be thinking about myasthenia gravis. Now, if you take our patients here, just a quick survey, everyone says they have double vision. You look at their eyes, even if I look at their eyes, I'm like, oh, maybe. Yeah, because their eyes aren't like this. Their eyes are like this. Instead of like right on top of each other, they're like this. Now, I can tell you that as a doctor, you know, it's a lot easier to diagnose this than it is to diagnose this. But as a patient, this is sometimes worse than this, because it's just annoying for everything to be slightly off, okay? And so the perception for the patient is that this is really, really, really bad. For the doctor, you're like, oh, your eyes look fine, okay? So if you were to ask the doctor, you know, is this, looking at the eyes, could I diagnose this? It'd be pretty hard to diagnose, because, you know, we'd be like, oh, I don't know. You know, maybe you just need some eye surgery or something. So an eye doctor may not actually diagnose this disease very well. An eye doctor is very commonly good at diagnosing myasthenia gravis. I don't think I've ever seen an eye doctor diagnose this disease, because it's just a little more subtle.
At what point in the journey of having this disease do the eye problems begin to manifest?
Usually it's a little bit later in the course. Usually the first thing that people notice is their legs, and then the arms, and then the face. But that could move, that progression could be very quick. Do you guys agree with that?
Mine was good.
Yeah, yours was quick. It went from legs to arms to, okay, to vision.
So how I remember with Patrick, he actually almost got the same time.
All three, huh?
Yeah, before he was diagnosed with Miller-Fisher variant.
Oh, okay. So that's why it was Guillain-Barré.
Yeah.
What about you, Nicholas?
Legs and arms.
Legs and arms, and the eyes came later?
I have a question for you, guys. Is there a possibility to have involuntary movement?
Is there a possibility to what?
To have involuntary movement in the part of the body?
Is it possible to have involuntary movements? Part of this disease? Not typically, no. It's not. You mean like a little jerk?
I remember a couple of days ago, my jaw started moving.
Your what test move?
My jaw.
Oh, twitches.
Jaw.
Maybe those are like
Could be
fasciculation.
almost.
Yeah.
I get finger and thumb.
Fasciculations, yeah.
Hot to go, hot to go.
Hot to cold, hot to cold. So, I mean, what happens is like, it's kind of like an on-off switch.
Night work is there.
Yeah.
Hot, cold, hot. You get twitches, and they get palsy. So I start getting that.
I think little twitches, we believe that that's probably,
Sometimes my arms, my fingers.
yeah. Your nerves are trying to get signals in there, and then sometimes it succeeds and sometimes it doesn't get a twitch, yeah.
Very good.
It was mentioned earlier about Sjogren's disease, and Sjogren's, the manifestation is a dry mouth. Does that also come later on, like the vision problems? Is it mostly the movement first and the dry mouth comes later?
Well, actually, I was, the double vision and dry mouth came together.
Yeah.
Sometimes I
Okay,
was
came
first
together.
to see.
Mhm.
It was a complete package. All together.
You're lucky one, you got
You
everything.
got the back one.
I go through everything.
All at once,
Uh,
you weren't wasting any time.
Plus paparazzi, dry mouth, double vision, tired, sick. I can move, I can walk, I can walk. I even have
That one was the first one to speak that.
I have when I was in the hospital, they sent me to see the specialist for this swallowing.
For
Oh,
trouble
just
swallowing, yeah.
For trouble swallowing.
Is that, and that's, a lot of that was fluid or, Dry mouth.
Everything.
yeah, a little bit of both probably.
So is the dry mouth treated separately with any of the medications that are out there for that? You treat it separately, you just drink a lot of water?
The reason is actually dry mouth and dry eyes, it's a symptoms of LEMS because you kind of block acetylcholine, which could increase sweat and salivation, and other you don't have it. So the acetylcholine participate in a way to saliva start working. So nerve send a signal to gland, and glands start producing saliva. So the transmitter between nerve and saliva gland is acetylcholine, but it's blocked, and it's blocked by calcium channel voltage channel blocker, and therefore people stop producing saliva and start producing tear and getting sick and dry. So the best treatment is just artificial tears or just water in the mouth or these candies that everybody now has, the hard candies. But if you diagnose right and you start treatment, it's get less and less, and then you start using less because you're increasing amount of acetylcholine, which works for you.
My dry mouth doesn't happen in the morning time. During the daytime, I'm pretty fine, but in the morning time, I do wake up with the dry mouth.
And I can explain you why, because your last medication you're taking at night, somewhere at 6 or 8, and then you have 10 hours no medication. So all your antibodies back, and they say, oh, fine, here sleeping, let us do our work, and then eating your acetylcholine.
Another side effect is the slurred speech, and does that also come later on? Patrick had mentioned it.
That's right.
Because, and so, is there speech therapy that's recommended, or?
The reason is, if it's not treated, it affects all muscles of your body, and this is your vocal cord, and it's your pharyngeal muscles, everything affected with the time. So speech therapy will help, but if you don't start real treatment, it helped the way, but you will still experience moderate problem to maintain the speech. Right?
I think if we, drugs that treat the disease are probably the best way to address the symptoms. Because if, there's nothing wrong with the coordination, there's nothing wrong with the brain or anything else, then it's not a stroke. So, so typically if we have a drug that's effective at improving the muscle movement and the muscle strength that helps them speak, that's the best way to improve their symptoms, including the speech.
So rather than treating just the symptoms, the goal is to really treat the actual cause of the disease, and so that's the hope with any studies that are currently being
Well, it depends on
conducted.
what you define as the cause of the
Right,
disease.
it's cause of the disease.
So the cause of the disease you could go after the immune system, okay, as Dr. Smirnoff has just discussed. There are different ways of going after the immune system. Plasmapheresis removes the antibodies, so that's kind of going after, and we don't really cure it. Then there's sort of more the next step, which is kind of a symptomatic treatment, and things like mestinon and 3,4-diaminopyridine are medications which have really boost the strength and improve, the quality of life and function of our patients. And then there's sort of more kind of supportive things like therapy and stuff like that. And that because we have, those are sort of more coping type of therapies, like figuring out if this is the best we can do in terms of getting your muscles stronger, what is the best way for you to get around? So that would be a physical therapy purpose. Speech therapy may be, given the limitations of what you can do with your mouth, these are the best ways for you to improve your communication. Yes.
Vaccines?
Vaccines are okay. Yeah.
Is that virus or antibodies?
Yeah,
That instead of
there's no reason to not have vaccines with this disease.
you have some now?
Do I have vaccines now?
So may I tell you something? When you work on vaccines, you really should have agent which you can develop antibodies against and then give it people. The good example like a plaque, this disease eradicated, or anthrax, it's almost eradicated, or polymyositis, because we found that the real cause for this disease. We develop antibodies against this disease. We develop vaccine which help you develop this antibody.
Well, basically, a
So-
vaccine just tricks the body.
Yeah.
That attacking on making the cells.
Yeah.
I think the moment we will find the smallest molecular mechanism when it's antibody developed in the LEMS, we can hit this, but we need to find.
Okay, the worst thing
vaccine for, there's no vaccine for LEMS.
No, natural, she said, like
Another immune
antibodies.
system disease can combat, I mean, not combat, add to this one, come back, even though you suppress it.
Yeah, I mean, patients do have long-term fluctuations, like go into kind of a partial or seeming remission, where it seems like the disease is a little bit less, active. And we see that with other diseases, other autoimmune diseases too. And honestly, I don't think we totally understand why, but that does happen.
Also, I've been diagnosed, it's called neurology, what is it called?
Neuralgia.
Neuralgia?
Which is the same as LEMS, right?
Mhm.
But anytime which is why I like to take medication and stuff, because when I calm myself, I'm okay. If I freak out, I have anxiety attacks, I do start twitching, like you said. I start worrying me, and I start going like this, and I calm myself down. So it is a lot mind over matter, how you think about it. Because the minute I freak out, my body reacts. So, and of course, that's normal. But with LEMS, it's really critical. So I do then start twitching, and I have to control myself.
Is there a particular age range when this LEMS becomes more prevalent or would certainly manifest? We have a more mature population.
That's
And-
where we tend to see LEMS,
And-
and it's correlated to some extent with the incidence of cancer. I mean, the non-cancer types are the ones that we tend to see in a younger population,
Younger meaning 30s, 40s?
No, younger than 50.
younger than 50.
Younger than 50.
Yeah.
So
More often
50
it's
and over?
60s and over.
60 and over.
It's more often 60,
We
65.
consider 40 to be young.
40 is,
Yes.
We count 60, we're 65, we count young. Young patients till 65.
That's right, you're young till you're 65.
Acco-
I like your thinking.
Yes, according to our government rules, you are only get older after 67. Then you can go to retirement. So it means 66 and a half, you're still young.
So does that make it harder to diagnose, because there could be so many other things happening, for those of us who are over 50? You really have to go through that checklist
Yes.
to decide what it isn't, right?
Yeah. The real reason why it's very hard to diagnose is it's rare.
Yeah.
And it's
Okay.
mimic sound.
And the truth is, as much as, we actually do teach all of our residents, all of our trainees about this disease. If you go and you ask all of our neurologists, everyone has heard of this disease, okay? And everyone has heard of it, okay? Everyone, unlike some of the other rare diseases, it's something that everyone's heard of, at least the neurologists. But most of them have never seen a case before. And if you had a patient who was unknown but actually had LEMS in front of them, most of them would miss it. Okay? Because they're just not thinking of it. Because you never see it. Of course, it's not going to be on your radar because, of course, you never see it. You never will see it, right? And it's a self-perpetuating.
I only read about it, or they
Right.
just told me about it in med school.
Yeah.
You're right, it's a very good question. But it's kind of hard to diagnose, and then you never blame the person who sent this patient for consult to you, because you may first glance and say, yeah, very, very similar, and only very subtle symptoms like increased reflexes with the time, and when I checked, actually like Patrick weakness, and he was very weak, couldn't sustain, then got stronger and stronger. And because Dr. Shea told me a long time ago, like 10 years ago, said, keep in mind it may happen. So this is kind of, you need to see it.
Yeah.
So as neurologists, you see this, and I'm glad to hear that you're educating your fellows and your students about this. But if there was a field of physicians that you would want to know about this, would it be those in the geriatric?
I would say
Yeah.
after 65, any kind of weakness, and our physicians now very well educated, they first suspected, especially with difficulty vision, swallowing, they suspected myasthenia gravis.
Right.
And they sent to neurologists, and I believe this is the best ever, the best first step. And then when patient come to neurologist, there's already our goal to get to the point, make a differential, and see which way it's going. Possible not a myasthenia at all. We may find something else. But now awareness about paraneoplastic syndromes, and not only LEMS, very high. And people start even checking paraneoplastic antibodies ahead, even before they send to us. So it's very good. I think our community, at least in Los Angeles, well educated, and because we have a lot of big hospitals, good teaching institutions like UCLA, Cedars-Sinai, USC, and we try to prepare future medical doctors have this high awareness that at a particular age we need to think wider. Not only think for this one symptoms like a dryness in the mouth can bring differential diagnosis on a list of 300 diseases. And you need to look through and decide what exactly is that.
So wouldn't it be wonderful to have a panel of LEMS patients attend one of your grand rounds or one of your neurology meetings so that they can see a patient with LEMS and not just hear about it from your experiences or just by happens chance. I know that there's
The state of medical education has changed, and that's because of healthcare economics.
right.
I mean, 20, 30 years ago, which is probably around the time when my medical education was starting, we used to take patients who were not super critical, and we would admit them to the hospital. And all the residents and all the medical students would get to see this is what a LEMS patient looks like. Nowadays, they're not sick enough to be in the hospital. So they come see me, I diagnose, and whoever happens to be in the hallway at the time will learn what LEMS is, and then the rest of the rest of my department is missing out on that education. And there's nothing we can do about that. We're not going to be admitting patients, and I'm sure our patients don't really want to come in the hospital anyways, but we were much better at educating our doctors, our trainees back, when we were allowed to do things like that.
Any other questions?
How much is, I find myself resting, say for instance, about 3 weeks ago, got out of work about 4:30 on Friday, and there was no movement until Sunday. Like I went Friday all the way through Saturday, and then Sunday I was like, I gotta get up. I've been just sleep too long. Is that something that's coming for us, or is it something that we can just?
Were you sleeping the whole time, or were you just kind of lying in bed?
Half and half. I probably slept majority of the time, but I mean, I would get up, maybe turn the TV on, but next thing you know, I'd probably fall asleep, and then I'd get back up, go to the restroom, back in the bed. It was like there was no, I was tired. Like, all the anxiety, no
motivation.
Depression.
I mean, this is supposed to be a peripheral disease, meaning not part of the brain, not affecting the brain. This is affecting muscles. So if you're excessively sleepy, you either like over-exhausted yourself at some point, and it's not directly related to the disease. As far as we know, we don't think it's affecting the brain, and it wouldn't make you sleepier than normal. But if you're having a hard time getting out of bed physically, but you're mostly awake, then that could be related to the disease.
Could that be a part of depression too?
Yeah, I mean, yeah, wanting to stay in bed is one of the things we do think about is depression. Sleep deprivation could be another thing.
I have insomnia.
You have insomnia.
Now I have insomnia.
The opposite problem.
Yeah.
And you know what, this has been wonderful. And I hope you enjoyed this. Well, happy to have the reunion here. And,
We just saw each other yesterday.
Oh.
We got another talk.
but I think this has been really wonderful and it's been very helpful. And I want to thank you for your questions and your sharing your stories, which are very personal. And because it helps everybody, all of us, to really get a better idea about this disease. And our ability for Global Genes is to let others who may be diagnosed and still not know enough about it, is to give them some of the resources that they can go to help them in that pathway. So thank you so much.
Thank you.
Thanks.
Very